Hello, I'm Dr. Sue Garland, and on behalf of the Toxic Shock Syndrome Information Service, I would like to introduce you to this video, Toxic Shock Syndrome, the Facts. Now, Toxic Shock Syndrome, or TSS, is a relatively uncommon entity, but a very serious one when it occurs. Early diagnosis is important, the condition is treatable, and the purpose of the Information Service is to alert you to the early symptoms. They are high fevers, low blood pressure, which a patient may notice as faintness, a sunburn-like rash, and other organ system involvement such as muscle aches and pains or diarrhea. Now, I'd like to introduce an expert in the field, Professor Patrick Schlievert from the University of Minnesota, one of the key scientists who identified the toxin related to toxic shock syndrome, now known as TSS-T1.
Toxic shock syndrome is an acute onset or a rapid onset disease caused by Staphylococcus aureus. And it's not all Staph aureus strains. It's strains that make a particular toxin. And in particular, the toxin we know as toxic shock syndrome toxin. That would be the major toxin. Now, more recently, we also identify streptococcal toxic shock syndrome caused by the group A strep, which is the same organism that causes the strep sore throat. In this particular case, that strep has picked up a toxin that's related to the staph toxin, and so giving it the ability to cause toxic shock syndrome as well. Well, toxic shock syndrome is defined by 5 criteria. If you have all 5, you have a definite case of toxic shock syndrome. If you're missing 1, you have a probable case, and if you're missing 2, you have a possible case. So the symptoms are a high fever, and it's usually greater than 102 degrees Fahrenheit. So it's a high fever, a red scarlet fever-like rash or a sunburn-like rash. That would be number 2. A third would be if the patient survives, the skin peels. And then hypotension or shock would be the 4th. And then the 5th would be a variable multi-organ component. And you need to have 3 of these. And they include vomiting and diarrhea would be 1, reddening of mucous membranes, liver enzyme changes, urinary tract shutdown, hematologic disturbances, in other words, low platelet levels. Combativeness or confusion would be considered a central nervous system component. So you can have any 3 of those, and that then make up the 5 criteria. Staphylococcus aureus causes toxic shock syndrome, but it's not all Staphylococcus aureus. It's staph that make a toxin we know as toxic shock syndrome toxin, or TSS-T1, as we call it. And that causes all of the menstrual-related toxic shock syndrome. Toxic shock syndrome can be divided into menstrual and non-menstrual. Menstrual makes up about 60% of all cases. Okay, and that's all caused by TSS-T1. Non-menstrual is caused by, half of it's caused by TSS-T1, and half is caused by staph enterotoxins B and C. Toxic shock syndrome, when it was first described, was an uncommon disease, but it was not rare. At that time, it was thought to be about 1 in 10,000 individuals. When the high absorbency, the super absorbent tampons were removed from the market, the incidence dropped to about 1 in 100,000, so making it pretty rare. Toxic shock syndrome is characterized by those 5 symptoms that I mentioned earlier. A typical case of toxic shock syndrome would occur on day 3 to 4 of the menstrual period. Now, prior to that time, there is a slow progression of development of symptoms. So patients would have vomiting and diarrhea. They'd have achy muscles, sore joints. They'd begin to feel weak. And these would get steadily worse until about the 3rd or 4th day of the menstrual period, when you have then abrupt onset of development of high fever, hypotension, the presence of a red rash, And particularly development of hypotension and the fever would clue you in that your patient should be considered as possibly having toxic shock syndrome. The red rash is sometimes difficult to see in people that have dark skin. It's also fleeting in other people. Once you have that constellation of symptoms occurring, then you can begin to do blood tests, etc., to fill out the rest of the criteria. Now, it's important to remember that when you're diagnosing toxic shock syndrome, that this is also a disease of exclusion. You need to exclude other diseases. Some other illnesses that you should exclude are streptococcal toxic shock syndrome, caused by the group A strep. Now, that disease would also occur during the menstrual period in menstruating women. Likewise, gram-negative shock would be another illness that could be mistaken for toxic shock syndrome. They overlap in many ways. And sometimes drug allergies, drug hypersensitivities look like toxic shock syndrome. And I think those would be the three big ones that you'd have to rule out. Well, the treatment of toxic shock syndrome is if this is a menstruating woman, then you remove the tampon, and assuming that she was using a tampon. If it's a patient that has toxic shock syndrome that results from an abscess or something like that, which can, by the way, be very difficult to find, you need to drain that abscess. You need to give antibiotics. And most Staph aureus that cause toxic shock syndrome are resistant to penicillin and ampicillin. And so you need to give, say, a cephalosporin or nafcillin, dicloxacillin, something on that order. And then fluid and electrolytes to maintain the blood pressure. The relationship between tampon absorbency and toxic shock syndrome, as I mentioned earlier, is that the higher the absorbency, the greater the risk of developing toxic shock syndrome. Now, in the early 1980s, the very high absorbency, the super absorbent tampons were removed from the market, so we don't have to worry about those anymore. But we still have tampons that have varying degrees of absorbency. And some people ask, well, what is the explanation for the absorbency? Why is it a predictor of development of toxic shock syndrome? And my laboratory put forward a theory which has become the accepted one, that the bigger the tampon, the more oxygen it traps, and when that tampon then becomes inserted, it takes that trapped oxygen and puts it into the vagina. The vagina is normally an anaerobic environment, so it's an environment without air. And Staphylococcus aureus, the bacterium that causes toxic shock syndrome, can grow in the presence or in the absence of air, but it only makes the toxin in the presence of air. So what the tampon is doing is providing that source of oxygen that allows the staph to then make the toxin. So again, a very small tampon won't introduce very much oxygen, and therefore would have a very low risk associated with it for developing TSS. As you go up to the higher absorbency ones, then you introduce more air and you pick up more risk. Okay, and that's why I've said that women should use the lowest absorbency tampon they can to control their menstrual flow. At least in the United States, when in 1984, when the really high absorbency tampons, the ones that had the polyacrylate rayons, and before that, Rely tampon were removed from the market, there was a significant drop in the number of cases of toxic shock syndrome. And the basis for their being removed was that the tri-state study, which is the gold standard study, the best study that's ever been done, that was done in our part of the United States, Minnesota, Iowa, and Wisconsin, showed that the risk of developing toxic shock syndrome correlates with the absorbency of the tampon, not so much with what the product is made of. So the composition, so risk of TSS is independent of composition of tampon fibers. So it doesn't matter whether it's cotton rayon. What matters more is the absorbency. Well, it's a really interesting question on whether toxic shock is associated with leaving a tampon in too long. Again, the tri-state study, which did the best study of this, showed that women that get toxic shock syndrome actually change their tampons slightly more frequently than people that do not get toxic shock syndrome. Now, armed with that information, the Centers for Disease Control recommended that women leave tampons in place from 2 to 6 or 7 hours. In other words, change them approximately what they were doing before, rather than, okay, that would suggest what I just said, is that you don't want to change them real frequently, because that might even increase your risk more. And likewise, I think you want to avoid really long periods of time. And for example, that's why the Centers for Disease Control recommended not using a tampon overnight. How I would advise a physician on what to tell their patients regarding the use of tampons. First, it's easy. If a woman has had toxic shock syndrome, she should not use tampons. She should not use them at least until she finds out if she has a significant level of antibody to toxic shock syndrome toxin. If she has that antibody, then she would be protected and it wouldn't matter. But 85% of patients that get toxic shock syndrome do not develop antibody, so 85% remain susceptible. So those people definitely should not be using tampons. Now, for the others, he or she, the physician, once the woman says, I would like to continue using tampons, what would you recommend? I would say to him, recommend that they use the lowest absorbency they can to control their menstrual flow. Know what the symptoms of toxic shock syndrome are in case they come on. Know what the early signs are. In other words, high fever and the development of dizziness, particularly upon standing. And if that happens, then go in and see a physician. And what I say today is don't go in and say, is there something wrong with me? Go in and say, do I have toxic shock syndrome? Ask the physician, do I have this? Because that might help key them in on it. Finally is to avoid using tampons overnight, particularly for that 12 or 13, whatever hour period it is.
Thank you for your interest. Should you have any further queries about toxic shock syndrome, please do not hesitate to contact the TSSIS or Toxic Shock Syndrome Information Service.